of Congo and South Africa. My name's Ms. Phyllis Kalele. I'm the Senior Liaison Officer, Africa Collaboration at the Academy of Science of South Africa, and I'll be the facilitator for today's webinar. To start us off, I would just like to remind us all of a few meeting rules. For the microphone and video functions, please, for minimum disruptions and when not speaking, please keep your microphone muted and your video turned off. Please ensure that your speakers are turned on and that you are connected to audio. During the question and answer session, please make use of the chat box. We will not be taking any questions live. So use the chat box to post your questions or any comments that you may have for the various speakers. These questions will be managed by myself, as well as the session moderator for the second session, Dr. Stanley Maposa. In terms of technical support, in case you are cut off, please refresh your screen and follow the wizard again. Do not worry, should there be an interruption of any kind, simply try to log in again and join us in the meeting. The same applies should the presenter be interrupted because of unforeseen events such as an interruption in the internet connection. For today's webinar, we have an English to French translator. To access this, please click on interpretation and switch from English to French. And just to remind everyone that will be speaking this afternoon, try and speak a little bit slower than the usual so that the translator can have time to translate from English to French. And with those few ground rules, I would like to officially open this webinar and to give the platform to two individuals to give us the welcome remarks. Dr. Stanley Maposa and, from the Academy of Science of South Africa. Dr. Stanley Maposa is the International and National Liaison Manager of the Academy of Science of South Africa. He is also the Regional Coordinator of the World Academy of Science, Sub-Saharan Africa Regional Partner. Dr. Maposa leads ASSAf's Overseas Strategic Partnerships, Member Liaison, Overseas Collaboration, African Collaborations, Gender in Science, Technology and Innovation, as well as the Young Scientist Liaison. Dr. Maposa and his team work to establish relations and maintain existing ones at bilateral and multilateral levels. Professor Leon Chilolo is the founding fellow of the Democratic Republic of Congo Academy of Sciences and Technology. He is a professor of pediatrics and hematology at Official University of Mbuji-Mayi in the DRC. He is a visitor at universities of Kinshasa and Lubumbashi. Prof Chilolo is the director of an educational research and training center that is associated with Mokole Hospital in Kinshasa, in the DRC. He is the scientific advisor of the Sickle Cell International Organization, and he is also a temporary consultant at the World Health Organization. Prof Chilolo is the co-founder of the REDAC, a network of sickle cell study in Central Africa. He is a member of the French National Academy of Medicine, as well as the recently founded Democratic Republic of Congo Academy of Sciences and Technology. Welcome, colleagues, to give your welcome remarks. Thank you.
Audible. Thank you very much, Phyllis, Program Director, distinguished speakers that are in this platform, Professor Chilolo, Professor Abdool Karim, Professor Kayembe, Professor Hoffman, Professor Sudesh, and Dr. Hippolyte, and all the other participants that are listening and joining us online today. I have the pleasure to send off these opening remarks on behalf of the Executive Officer of ASSAf, Professor Hibda Sudial, who could not join today because of conflicting programs. at the university where I left here this morning. And also the whole leadership of the academy that has assigned me to come and open this opening remarks. A few remarks that I have are that this meeting today is historic in the sense that it's the second phase of discussions that ASSAf is having in partnership with our peer academy in the US, the National Academy of Sciences, commonly called the US NAS, as well as the DRC Academy that has just been formed, as this is already said. The first phase of this webinars, the US NAS approached the Academy of Science as a lead academy in the SADC region to mobilize other academies. We mobilized the Botswana Academy, the Eswatini Academy, Zambia, Zimbabwe, Mauritius, as well as SCIAS, the South African Young Academy of Science that is present here again today. And through that particular phase, webinars were put together to enable a dissemination of policy briefs that had been developed by the Partnership for Evidence-Based Response for COVID-19, PERC, on public health and social measures. And that was quite an interesting discussion that happened through those initial webinars. And then we are now in the second phase. Further on, the US NAS approached us to do this particular that we have today, which then brings in the DRC Academy of Science, which is a newly formed academy, to be able to just test drive this new academy, be able to see how far they can be able to do in the future after they launch the academy. But not only that, to be able to discuss this balance between the public health issues as well as the social measures that have been put in place between the two countries, that have a relationship over years, and also bring in the Young Academy to show us how young people as well as young academies and young voice are taking this discussion in the social media space. How then the balance is being maintained between the two, the public health space as well as the social measures that have been put together by government, and also the huge discussion that has been going on in the social media space around these issues. So we are very, very interested to hear what the two countries are saying and what is happening in the two countries around those spaces. But to finalize my comment, I wouldn't end up by not telling you a little bit about what the academy is itself, what is its role in some of these discussions. The Academy of Science is a member-based think tank that is recognized and mandated to an act of parliament in South Africa. We do primarily two things: to recognize excellent scientists, of which we currently have close to 600 of them as members of the academy. And we also have a young academy that is hosted at ASSAf, the SCIAS, which they will tell you more about that later as they come in to speak. Secondly, our mandate allows us to provide science evidence to policy making process, to government, as well as to society. And that's why we are here today, such that our discussion here is to talk to policy issues around this balance between public health and social measures. From 1994, when this academy was formed and patroned by the late President Nelson Mandela, it has grown leaps and bounds in its ability to convene meetings like these ones, to put out social statement and the scientific statement, and all forms of statement from a scientific point of view that have been taken by the government in its policy making process in the country. Some of the work of the academy has been recognized in the National Development Plan and other documents that are used by the government in its work day to day. Without wasting much of your time, ladies and gentlemen, I would like to welcome you and say, let us enjoy this discussion and contribute as much as we can so that we can be able to influence the policy making system around the topic we're discussing today. Thank you so much.
Thank you so much, Dr. Maposa. And without further ado, welcome Professor Chilolo. Professor, you're muted. Please unmute.
Yes, thank you very much. Can you share my slides? I sent my slides. I have just some slides to share with you.
Mm-hmm. All right. Tato, please share the slides.
Is it okay?
Yeah, you can go ahead.
Thank you very much. I'm very grateful to the organizers for inviting me to give these introductory remarks in this interesting webinar. And as you know, last month, the Congolese Academy, next slide, please. The Congolese Academy made this official release under the high patronage of the president of DRC, Mr. Félix Antoine Tshisekedi. The Congolese Academy of Science is an independent organization intended to promote science and engineering and strengthen their influence in the Democratic Republic of the Congo. The next one. Here are some of the main objectives we are pursuing. We want to promote dialogue and information exchange between policymakers and scientists to ensure the involvement of ASSAf in national policy, to strengthen science, technology, and innovation capacity in DRC to respond to challenges and opportunities towards achieving the development of our country, to facilitate access to appropriate technologies through technology transfer and provide access to research and technical knowledge, and also to provide a national forum for publication of research and exchange of ideas among scientists, technologists, industries, and also traditional practitioners and opinion leaders. Next one. Here, I would like to illustrate our intentions with some examples. Here you can see, please, the next one. Yes, here, thank you. Here you can see, please. Yeah, you can see an example of innovative technology. It's a mobile lab that does not need a cost for building. It's immediately available. It's a compact and mobile model, and it's modular and evolutive. You can use it with 4 boxes, and we can constitute a practical laboratory. Next one. In this lab, the next slide, please. We have involved young scientists in some of the public health challenges and research in DRC. On the left, you can see how this example in the use in course of the Ebola epidemics in Guinea, and on your right is you can see a young scientist who are involved in the malaria resistance study in a rural area in DRC. And finally, the next slide, I would like to say that according to the COVID-19, we involved students of medicine in a survey, and the young scientists were involved in the publication. Here's just an illustration of a dashboard for monitoring preventive measures in response to COVID-19 outbreaks in DRC. In red, you can see that this is the score of the population density, and in blue, the distanciating, and in green, masking. You can see that the low score is due to the use of masking. Even in the specifically at the end of the day, people does not use the mask, and distanciating is not respected. I think this is just an example in which way we would like to involve young scientists in the National Academy and in the different projects we have in DRC. Thank you for your attention.
Thank you very much, Professor Silolo, for those brief welcome remarks. And without wasting more time, because I see we are already around 6 minutes overboard, I would like to welcome our keynote speaker for this afternoon, Professor Quarraisha Abdool Karim. Professor Quarraisha Abdool Karim is a National Research Foundation A1 rated scientist. She's an infectious diseases epidemiologist and Associate Scientific Director of the Center for the AIDS Program of Research in South Africa. She is a professor in clinical epidemiology at from the Columbia University of the United States of America, and she is a Pro-Vice Chancellor for African Health at the University of KwaZulu-Natal in South Africa.
Vous ne comprenez pas, ainsi je pourrais vous traduire.
Sorry, somebody's mic is on. And finally, I will not read the whole biography. She holds fellowships at the National Academy of Medicine, the World Academy of Science, Royal Society of South Africa, the Academy of Science of South Africa, and the African Academy of Science. Welcome to the floor, Professor Quarraisha Abdool Karim.
Thank you. Dr. Quarraisha Abdool Karim.
Thank you very much, Chair, for that very warm and generous introduction. I just want to check, because I'm very nervous about the technology these days. You do a number of presentations and you never know. Can you hear me and can you see my slides?
Yes, loud and clear. We can hear you and we can see. Thank you.
Wonderful. So distinguished guests, friends and colleagues, it's a real honor and pleasure to have this opportunity to share with you COVID-19 lessons learned in responding to health epidemics in Africa. And I just want to start by congratulating Professor Silolo and his colleagues for the launch of the DRC Science Academy. I think it's a major milestone and we look forward to working with you in the future. And I feel deeply honored to be part of this inaugural partnership with you and your colleagues. Okay. For some reason, my slides are not advancing. Okay, here we go. Okay, so what I'm going to do is just provide a quick update of the COVID-19 pandemic, particularly locating Africa and the magnitude of the problem there, and then in terms of the
générale de l'épidémie du COVID.
The simultaneous translation is actually, is it possible for it to be not heard by all of us, or is it going to be parallel and loud? Chair, I'm just clarifying.
Tato, can you, Tato?
I will sort it out. Apologies for that, Prof.
Yeah, no problem. So the few lessons I wanted to touch on is around political leadership and coordinated responses, the importance of mutual interdependence, the critical need for strategic information and infrastructure. And then I want to focus a little bit on changing the paradigm in Africa from where we do a lot of clinical trials, but where we need to be leading the knowledge generation and particularly addressing the key and critical challenges that face us, including moving to local manufacturing and production capacity. And I'm talking more than finish and fill stuff. And then some of, just to, as a sort of segue into the next two presentations, the challenges with COVID, particularly balancing saving lives and livelihoods against the context of many challenges that face us in Africa. And not to forget that we have multiple unfinished epidemics on the continent that we need to deal with in parallel. So just globally, we have 134 million cases of SARS-CoV-2 and about 2.9 million deaths. And you can see on the left, there's been a steady increase in terms of new cases. And then around February, we started to see a dip. And then we're seeing another rise. And I think it is amazing how rapidly this virus has come into our lives, no matter where we are, and has disrupted it for the past 15 months or so. But in the grander scheme of things, if you compare it to the Spanish flu, for example, where over 50 million people lost their lives, we're still doing pretty well in terms of containment of a more extreme manifestation in terms of deaths, as hard as that may sound. In terms of Africa, we have 4.3 million of the cumulative cases up to the early April, and about 115,000 deaths. And what we can see here also is that the 5 countries that contribute about 64% of the infections are actually South Africa, Morocco, Tunisia, Ethiopia, and Egypt. We can also see that many countries in Africa saw a first wave, and more of greater concern is the second wave, which, as we can see in this particular slide, the peak of the first wave compared to the second wave much sharper, much more rapid, and certainly quite substantially worse than the first phase and first wave. And I think that one of the really important differences that we see in terms of responding to COVID was the leadership from the African Union very, very early in the process. Already by February last year, we were having key guidance and decisions being made. And I contrast that to, for example, earlier Ebola outbreaks, so continued Ebola outbreaks, I should say, other epidemics like HIV, TB, and malaria, where we've been so slow in terms of responding. And I think the last Ebola epidemic certainly was a reminder on the challenges that when you have epidemics, they can very rapidly escalate to pandemics, and that these infectious organisms can spread anywhere in the world. And these days, where as a global community, our worlds have shrunk and we're traveling all over, it's so easy for an epidemic in one country or one part of a country to suddenly become a pandemic. And an important investment made by the African Union is the establishment of the Africa CDC. And I think under the leadership of Dr. John Kengasong, we have seen just amazing leadership in terms of coordination and support being given to countries that is quite unparalleled. And, you know, here I just give you some examples of the committees and initiatives and partnerships that have been launched, all the way from task forces to ways of accelerating testing, but also when some of us started to find that we were joining the global queue and competing with wealthier countries for reagents and test kits and diagnostic kits, and now with just personal protective equipment. The Africa CDC was, through with the African Union, able to step in and create ways and means of procurement and distribution across the continent. That's quite new and different, but I think an important lesson in terms of how we can build and invest and grow. And you can also see here in terms of the types of equipment that was supplied in quantity, the number of healthcare workers that have been trained in different facets and aspects of epidemic response. Truly phenomenal work by Dr. Kengasong and his team. Now, we've also learned in responding to Ebola and also HIV on the continent, malaria to some extent, and hemorrhagic fevers, that multi-sectoral responses are critically important. And how key it is in that multi-sectoral response that it's not just restricted to government and the private sector, but involves civil society. And these partnerships with communities have been really, really key. At the end of the day, a lot of the interventions that we're doing are to support our people in our communities and to ensure that we're saving lives and mitigating against particular economic and social outcomes that come with the terrain of disasters and emergencies and pandemics and epidemics. And we've learned this many times about the importance of doing things with people rather than on people. We've seen that with HIV, how community engagement has fast-tracked the scientific knowledge generation process. We wouldn't have as much as we have had, not just in the knowledge generation and the amazing advances we've made in terms of antiretroviral treatment, the expansion of many, many prevention tools, to the point where in 2016, the UN Secretary General could announce that we can end AIDS as a public health threat. Took nearly 40 years, but we're there, and we're on a good trajectory, but it's still not finished. Importantly, when ARVs was discovered, how we were able to then ensure access and equitable distribution and bring prices down and so on. And that was all because of this nexus between science and activism and engaging communities and respecting them, not just in terms of having them as place on the table, but also being true partners. And in COVID, we've seen this pivoting from that infrastructure to enhance our responses. For example, in South Africa, something like 55,000 community health workers were able to go and do door-to-door educational outreach, identify individuals with signs and symptoms and refer them for testing to mobile testing sites or clinics where the diagnostic testing was being done. In South Africa, another example is where the Minister of Health, who had already established a ministerial advisory committee comprising mainly scientists and clinicians and public health practitioners, to set up a parallel ministerial advisory committee for socio-behavioral change, where he drew on key leadership from faith-based organizations and other movements within civil society to also additionally guide him in a specific vaccine advisory committee. I think the issue is when we're faced with something new and something unknown, as human beings, our immediate reaction for most people is anxiety and fear of the unknown. At the same time, you have governments trying to implement public health measures and interventions, and a lot of what is being put into place sometimes results in quite severe constraints in terms of individual liberties. And in COVID, for example, national lockdowns that were instituted across many parts of sub-Saharan Africa and done very quickly, very slowly, before we were seeing cases beyond 1 or 2 from international travelers, was also dependent on trust between government and its citizens. And how do we then not abuse that power that comes with some of the interventions that get put into place to enable more agency? And this is where that community engagement and partnerships become important, because how do we empower individuals and how do we enable individuals so that they can shift to self-efficacy, and we do less of what is government directed and controlled and policed and monitored, to where individuals are empowered and have the knowledge and efficacy to implement the measures that need to. And I think this is best captured in this concept of Ubuntu that we use quite widely in South Africa, which in essence is I am because you are. And this type of collectivism it's not about sheep mentality, but it's really about how do we work together, where each of us do things that protect ourselves, but also protect others that we work with, that we live with, that are around us, our friends, family, colleagues, etc. Now, I just want to move on to some of the technology and talk a bit here in terms of our, in epidemics generally. One of the important things is to quantify the magnitude of the problem and characterize it. And to do that, you need to be able to diagnose cases in a robust and reliable way. Because we had invested during the Ebola outbreak and epidemic, and also with HIV in PCR platforms, we were able to use those very quickly to develop capacity for rapid sequencing for SARS-CoV-2. And be able to do those testing in many countries in Africa. And if that technology, and I was just marveling at the 4-box mobile lab that Professor Shilolo just shared with us, is the kind of equipment, innovation, capacity that allows us to respond rapidly. Together with that, we've also seen a rapid evolution in technology. And as with HIV and Ebola, the way we can move from these very complex, high demand in terms of human resources and equipment type diagnostics to rapid point of care diagnostics, the better able we are to respond to the epidemic that we face. And we're seeing that already with point of care, both antigen and antibody diagnostics now available, and a growing number of those. And because the diagnostics are such an important gateway to both treatment and prevention, and proper triaging of individuals in terms of quarantine or isolation, it's such an important investment and capacity to have in place in terms of impacting transmission chains, and also for appropriate treatment and management of those with severe disease. What we saw is, having built this capacity and having it, we suddenly were met with extreme reagent shortages, and then with the kit shortages. And I'll come back to the reminders these have in terms of some of the remaining challenges we have in terms of epidemic and pandemic preparedness. I think what was also phenomenal is, within a short space of time, how capacity was built in terms of meeting the demand. And again, just an example here of the small numbers in about this time, March last year, of PCR tests that were being done. And then if you look a year later, we're doing like up to 50, 60,000 tests a day. So to expand capacity and have this high volume throughput takes investments at many levels. And I wanted to move on now to another lesson, which is the importance of strategic information and surveillance. And I think in Africa, health information systems are not particularly strong. We have had some progress in terms of HIV, where better surveillance systems have been developed in terms of monitoring the magnitude of the HIV epidemic at a country level, at a district level, and also in terms of using data to monitor responses and the impact of interventions being put into place. And we've been able to use that same sort of technology of geospatial mapping of where cases are in COVID to also prioritize hotspot areas and intervene to mitigate ongoing transmission and referrals and hospital care preparation. What's also important as part of the surveillance is how ongoing Sentinel surveillance, where detailed and more comprehensive sequencing of viruses over time has enabled us to identify this emergence of a new variant of SARS-CoV-2, namely 501 YV2, and by national surveillance systems and connection of these Sentinel labs, we've been able to track the distribution, the source and spread of this new variant. This new variant being identified has also added a sobering touch to some of the excitement we've had in terms of finding vaccines. And the sobering piece is that these new variants reduce the potency of the efficacious vaccines that have been evaluated, and adds to the need for us to have these interconnected systems where the surveillance and interventions being rolled out are very carefully monitored, and that we monitoring with sophisticated technology, particularly when dealing with viruses that mutate so rapidly. Any variants of concern, mutations do happen, of course, but it's the mutations of concern that enhance, as we see here, the transmission of the virus. But I think the slide also flags for us that I think, with the first wave, it wasn't as bad as we were anticipating it to be. I think, when we saw images of the epidemic in Italy or in the UK or in the US, there were these really horrifying stories of overwhelmed hospitals running out of oxygen supply, running out of PPEs, and COVID arrived through some international travelers and more affluent people within communities. They then seeded through contacts, and we had a little epidemic. I think many countries felt they had over-prepared for it. And so even though we had wind and advance notice of the new variant of concern, there was a certain amount of complacency. Well, let's carry on life as usual. And there we are. Within a matter of days and weeks, we saw this taking off, more devastating, more transmissible, more cases within families, and we were less prepared to deal with the severe cases. And although we were able to manage some of the cytokine storm manifestation, we saw more viral disease, and we also saw the coagulopathies that come with more advanced beyond immune response stages. And now, of course, we're seeing a growing cohort of people with long COVID. And it's a good opportunity to raise that while we've made great progress on vaccines, we've not done the same in terms of our treatment efforts. So I'm going to turn a little bit to vaccines now, and we know how much vaccines have impacted our health within Africa, particularly in terms of child survival and enhancing our development indices through reductions in infant mortality rates and so on. But not surprisingly with COVID, I think we were all, what was surprising in COVID was, even though we knew a vaccine, was how fast we were able to do, quite unprecedented in medical history, that in April or March last year, we were talking about vaccines, and there were all these candidates, and some had moved from to clinical evaluation based on investments that had been made with the first SARS epidemic, and ongoing work by many people across the globe in terms of responding to other coronaviruses, etc., that we were able to pivot rapidly and amazingly today have 10 efficacious vaccines that are available. But I think that some of that in Africa, we saw very early political support for vaccines and partnerships. We were conducting clinical trials, strengthening our regulatory oversight capacity, and the Africa CDC even established the CONVACT consortium to facilitate work on vaccines. But I think that participation in vaccine trials is one thing, as we've learned. It's access to the vaccines once we have ones that are efficacious. And I think there's a real gap and need for greater leadership and investments in innovation, strengthening manufacturing and production, more than fill and finish type capacity, but also in terms of expanding our capacity. And it shows how monopolies in terms of these life-saving devices and technologies is just not on in an era where we are going to face increasing numbers of pandemics and epidemics. And I've just listed a few of those here. And I think as we think about vaccine access, we can take a leaf out of the book for HIV, where through global solidarity and structures like Global Fund for AIDS, TB, Malaria, Unit 8, PEPFAR, etc., and government investments, national government investments, we were able to ensure by 2003 and 4 equal and equitable access of ARVs. And I think while we have COVAX, we have to do a much better job for ensuring that the COVID-19 vaccines that are there and available is actually available in an equitable manner. And a reminder that in dealing with pandemics, that everyone needs to be safe for all of us to be. So you can't just have one country or small groups of individuals protected, because we can see with the mutants of concern that arrives that nobody is safe until everybody is safe. I wanted to touch on very briefly issues of gender inequity, because we see this epidemic after epidemic, that at the front line, whether it's about healthcare work, manufacturing, retail, whether it's in the formal or informal economy, women at the front line. But what we've not been able to do, even though in HIV, we see young women 15 to 24 years having up to 8 times more infection compared to their male peers, we still continue to see gaps, and this SDG goal 5 around gender inequity keeps widening, and women are always bearing the brunt of this. In COVID, we've seen how not only were they bearing the brunt in terms of frontline workers and carrying the burden while caring for people in terms of PPE shortages, etc. But they also have the increased burden with national lockdowns and states of disaster in terms of increasing responsibility for household chores, childcare, and even in settings where schooling was interrupted of homeschooling. But I think the worst manifestation of gender-based violence that we see under normal circumstances and not on is around the shadow pandemic of gender-based violence. And this is just some statistics from the UN Women team, and you see 243 million instances, and you can see all these statistics, and I hope when the slides are shared you can look at it in greater detail. But we can see in terms of multiple parallel pandemics that we have to deal with, while Ebola and HIV enabled us to create and rapidly pivot diagnostic platforms, the community outreach programs, medical access, research infrastructure, it also created and undermined some of these other pandemics and epidemics that we're dealing with, and we have to do a better job in terms of managing that. I think with COVID, we also see another epidemic which is more silent and hidden, which is that of non-communicable diseases and opportunities for us to address it. And I think while we have this whole lot of options and increasing options and new challenges in facing COVID, I think the challenge really in epidemics is how best do we institute each of these measures, and which of these measures do we do when, and to what extent do we implement it. And I think an ongoing challenge that we face with this epidemic, as we have with others, is how do we balance saving lives and livelihoods? And COVID-19, it has flagged the first recession in Africa in 25 years. We don't have great growth rates, but we've gone from -2.1 to -5.1% in 2020. And when we take into account all the social incohesion we have and the distress in terms of displaced populations, rapid urbanization, high density occupation in low cost housing, wars and conflicts, etc. This is an enormous price that we pay each time we have an epidemic and need to do better. I wanted to close with a few slides in terms of science in the 21st century. And I think it certainly has changed in terms of us simply being, as scientists, knowledge generators, to being advocates for strong policy and practice. But also importantly, we're seeing increasingly to be trustworthy communicators to our peers, to key stakeholders, to the public. And that we also appreciate better the importance of co-knowledge generation that is inclusive, that's more equitable, and takes our diversity fully and inclusively into account. The pandemics have provided us a new lens for the nexus between science, politics, and global health as we continue our efforts to address inequities and disparities in SDGs. But while COVID has made science access possible, it has been to those with access to data and internet connectivity. And I think this webinar is an example of that, is who is unable to join. But this increased access to real-time data, we've increasingly see the general public using key concepts and themselves analyzing each day's reports and cases. We've also seen explosion of articles and rapid publications. But with that also comes challenges of providing trustworthy data, good data to the public. And as you can see from the Zepiro cartoon, that we have experts that have sprung up overnight through WhatsApp, Google, YouTube, and Facebook. But I think even amongst us as scientists, despite our huge responsibility of giving scientific advice in the midst of minimal information and uncertainty, sometimes there is a lack of humility in terms of recognizing and acknowledging what we know and what we don't know. And so when we start masquerading personal opinion as science, it's a very dangerous thing. Also, when egos take over and you have those who want to be in the spotlight and being the experts, or worse, those who sit in their armchairs and have the wisdom of hindsight. So these provide uncertainty and undermine the value science brings in the context of pandemics. And we as scientists need to stay in our lane and present the data in a balanced and as factually correct way as possible, and not take the science and use it to become politicians. So there are, in conclusion, no silver bullets and quick fixes. But I think we have to appreciate our mutual interdependence, the importance of communication and engagement, the importance of strong health information systems, that scientific evidence, while at the core, in many times in new epidemics, we're dealing with a lot of uncertainties, and we don't have the luxury of what we usually have in our scientific endeavors to debate and discuss our differences of opinion, to replicate our experiments and get consensus. Decisions need to be made with incomplete and best data that's available. But that there are challenges, and that in terms of behavior change, stigma and discrimination. But most importantly, I think even as we address all of this through science, is these fundamental structural issues that are ongoing challenges, gender equity, and it's up to us and our countries to make greater investments so that we can be better prepared for the next pandemic. I thank you very much for your attention.
Thank you very much, Professor Quarraisha, for that beautiful presentation. You've given us quite a bit to ruminate on, and you raised some very key issues and lessons that, you know, for some of us had not even thought about. And I just like the way you ended by saying that scientists need to stay in their lane, leave the politics to politicians, and the fact that there is no silver bullet in dealing with any pandemic. And also another point that came up is that if the vaccine is not accessible to everyone, then the whole world basically is not safe, as long as some have and some do not. And then one other key point that I would also like to reiterate that you raised was the issue of gender equity. I mean, this pandemic has really just reminded us about how so many things just turn the tables for women, and it is important to consider our responses from using a gender lens to any kind of pandemic. So looking at the time, I see it is 8 minutes to 3 o'clock South African time. And just to try and catch up, I'm just going to move over swiftly to the next session, which will be moderated by my colleague, Stanley Maposa. Dr. Maposa, you have the floor. Welcome.
Thank you very much, Phyllis. Thank you very much, Professor Abdool Karim, for the keynote address. I'm going to call upon two speakers in this sub-session. They include Professor Jean-Marie Kayembe. I will not read the entire profile. I think you have received it, but safe to say he is the professor at the Faculty of Medicine at the University of Kinshasa in DRC. And immediately after him, we'll have Professor Karen Hoffman, an ASSAf member, as well as a director of the South African Medical Research Council and Vice Center of Health Economics and Priority Setting. These two are senior scientists that are members of the academies in the two countries, and they will give us, a snapshot around finding balance between public health and social measures in the two countries that we are discussing today. Let's start off with Professor Kayembe. Over to you, and then when you finish immediately, Professor Karen will come through. I suspect that's your presentation, Prof. You can go ahead. He's muted. Can you unmute him if you have power to do so, Ato? He's talking, but we can't hear him. We can't hear you, Professor Kayembe. Professor, are you hearing me? Now we hear you. Go ahead.
Okay, thank you. Thank you very much for inviting me. I am French speaking. Don't care with my broken English, please. I have no conflicts of interest in this presentation. I'll little show you how was COVID managed in DRC until now. After that, I will show challenges and lessons learned in DRC now. The first case of COVID was diagnosed in DRC on March 2020. And the organization of the response is led by the President of the Republic, and the government is involved with a technical commissions with led by Professor Muyembe, which is a very great virologist in our country. After that, we are doing this response relying on all the provinces in our country and health zones also. I try to show now in Congo, 23 provinces are now experiencing COVID-19. Just 3 provinces are free of COVID until now. And you can see on this slide how was the first wave of COVID and the second, which is now slowing, and we hope that we don't know if we will experience a third wave of COVID. We are afraid of that, as in all the countries now. The total number of confirmed cases is 28, and we now have around 750 deaths. You can see that the mean age of patients is around 41 years, and we have patients even under 1 year, 10 months old. And according to the sex ratio, we have 2 men for 1 woman. And you can see that people are treated at the hospital or at the community level, implicating the health zones. That's our strength in managing COVID-19 in DRC. We can see that for 3 to 4 dead patients, I want to say that we have the delay in the reference of patients. 3 to 4 patients, the diagnosis was made after post-mortem, that show that we have a big problem with the reference of patients who come at hospital very, very late. It's a big problem in managing COVID in our country. And now people are talking about factor limiting extension of COVID-19 in Africa. We, as in all countries, we think that the younger population showing a low risk of comorbidities, and maybe environment is helping us with the temperature and humidity limiting propagation. Maybe we can think about cross immunity, even if we have not really shown this by evidence-based experience. Outdoor lifestyle with ventilation maybe could be protecting for our population living in suburbs. Is there a genetic protection? We know that 3 months ago, they were talking about the gene of Neanderthal. But the big problem is that in all our countries, we have screening limitation, maybe leading to under-reporting of cases. But a big strength is that we have now a big experience in managing recurrent epidemics such as Ebola virus disease, cholera, and so on. What are challenges now? Pandemic has really economic impact. This impact on individual and the community behavior, also on the societal psychology due to stress and uncertainties. We have to rethink organization of the family, of the city or the state. There is a need of adaptation to a new situation. Will this adaptation be temporary or sustainable? What is the community reaction to this pandemic? We think that it's unpredictable. Uncertainties do exist, and we have different forms of response to this disease. COVID-19 leads to social inequalities in vaccine production and distribution, in access to medicine, such as monoclonal antibodies, which are not available in our country because they are very, very cost. Pharmaceutical industry war against old repositioning molecules, such as hydroxychloroquine, which is used in our country and in many other countries in sub-Saharan Africa. What will be the state reaction to the economic slump? We see that in developed countries, the government can help people or industries or people to economic, but in our country, it's very, very difficult to help people during this economic slump. Social measures lead to psychic pressure and men's decomposition. There is a need for restructuring men through philosophy, theology, sociology, anthropology. We need really a multidimensional response to this pandemic. What is the social impact of health measures in DRC? We know that the government has decided lockdown of school closures, market closures, physical distancing, other barrier measures, wearing face masks, and washing and hydroalcoholic gels. All these impacts on the society due to the stress, difficulty of accessing to healthcare, household conflicts, household income, precociousness, school dropout, unwanted pregnancies, juvenile delinquency, and school calendar disruption. This pandemic has a great impact on the society. What are lessons learned in DRC? Our strengths are the decentralized health system organization with health zones. And we are relying on these organizations to take care of patients at the community level. And at the beginning of the pandemic, we had lab training for some healthcare workers in Senegal. That was very, very important because they are trainers of trainers in lab to diagnose SARS-CoV-2 in DRC. We have now a great expertise in epidemic management. We are now dealing with the 12th outbreak of Ebola. And the organization of the response around the multisectorial committee and technical secretariat was a very great opportunity for us. And we are, we profit with partnership with WHO and others. But we have some problems in the identification and equipment of Center for Treatment of COVID-19. And we have provided the system with the dissemination of a fragility criteria to show who can be treated in the community or to the hospital. And we have provided a therapeutic protocol, and also we are doing advocacy for equipment in oxygen delivery, extractors, pulse saturometer, and so on. And we used to train people in the protection and how to cure COVID people in severe cases. Pandemic of today means also we have to get ready for pandemics of tomorrow. We need prompt and appropriate response. Measures in developed countries are not always appropriate to our context. There is a need of strong political engagement. Let me make some recommendations, such as epidemic must be an occasion to strengthen health system, such as infrastructures and human resources. And we have, as scientists, provide policymakers with reference tools relying on research and publication. We have to make modeling for the prediction of epidemiology, prediction in the diagnosis, clinical and prognosis. It's necessary to develop multidisciplinarity, sociology, ethnopharmacy, health economics, and so on. Strengthening research is mandatory, using natural resources and also developing medicinal plants. Strengthening targeted communication is very, very mandatory against social cultural barriers, either with vaccine. We'll start vaccination in DRC next Monday, but we have many, many problems with social medias and with message against vaccine and so on. It's very, very important to have an appropriate and targeted communication for people. I really thank you very much for your ear.
Thank you very much, Professor Kayembe. Thank you very much for all the good points that you have put here forward. Especially, I love that you said we need to prepare for the next pandemic, because some of these things will continue to happen. And therefore, scientists, policymakers, and everybody must speak to each other and continue to prepare for these things. Professor Karen Hoffman, it's your opportunity to make the presentation. while you're coming in, those that are writing questions, continue to write questions, because we'll take them all at the end because of our time. And I've also been told that the translator, the interpreter for French, has run into some challenges. We hope and believe she'll come back to the translation table again. Professor, Ren, over to you. I don't seem to see Professor.
Yeah, sorry.
Professor Karen Hoffman.
Yeah, thanks.
Yes.
Sorry, can you put the slides up, please? Thank you.
Okay.
Tato?
Tato, can you put the slide on?
Sure. Please could I ask
the
person that is sharing the screen to stop sharing so I can go ahead. Thank you.
Yes, that's what I'm trying.
While I'm waiting,
yes,
I just want to say thanks.
Thank you.
While I'm waiting, thank you for inviting me. Bonjour to everybody, and please forgive me, my French is not what it should be. A lot of the things that I'm going to say, you've probably heard already from Quarraisha, but I hope I can give a little bit more sort of granular detail. And today I want to just talk about the role of scientific advice and public engagement for better policy making during the pandemic and some of the things that we've learned in South Africa. Next slide. Okay, so sorry, can you just give the first slide? Yeah. Can we go right to the beginning? I don't think that's the beginning. Is that the first slide?
Yes, Prof.
Okay, so what is the role and importance of scientific evidence? So I just want to talk a little bit about this, and that is that clearly it's crucial and policymaker engagement is essential. But our experience in South Africa shows that the evidence itself is only part of the landscape. A lot of the decisions are about the political economy. And what do we mean by this? So the political economy is a term that's used to describe multiple actors who compete for finite resources and power. Yes, it's about money and power. And these people assess which policies will provide the most beneficial results. And the actors include a group of individuals who are included in government, academia, industry, civil society, and international agencies. And international agencies actually do have quite a big impact on these kinds of decisions. So, for example, the role and importance of scientific evidence. In addition to the vested interests in sub-Saharan Africa, we have some conditions in place that sometimes prevent good policies for health from being implemented, even in the face of strong peer-reviewed evidence. And we've had quite a lot of experience in South Africa with regulatory capture and industry-funded research. So we need to be aware that these kinds of issues, not necessarily from COVID, this experience, but as Dr. Abdool Karim explained, the HIV epidemic led South Africa to be able to, for example, sequence the variants much earlier than any other country except the UK. And we know that industry-funded research is also critically important, but also they have their own views on this. And in general, in many countries, there is a lack sometimes of policy coherence between public health goals and economic growth. And I think that you can see, we saw that in South Africa. There were a lot of complaints that public health was somehow being privileged over economic growth. So I just want to say that it's not just about the evidence. It's critical, and I'm a big believer in that, obviously, but I'm also very aware that there are forces at work that don't necessarily see that. Next slide. So in South Africa, there were some specific lessons, and there were also global lessons. It's already been talked about, but this Ministerial Advisory Committee and all the various subcommittees were critically important in South Africa. That was a big lesson that we learned. And clearly, South African academia was very well poised to advise the Ministerial Advisory Committee. It included economists, virologists, epidemiologists, and public health practitioners. Nobody always agreed. It wasn't like there was consensus, but I think it was really important that we had this Ministerial Advisory Committee. And there was publication of manuscripts and information on clinical trials of vaccines. But there is new information coming out all the time. The pace of research is unprecedented. The challenges that are associated with the translation of fast accumulating evidence for policymakers and communities, many of whom are not well versed in health, is really unprecedented. And preliminary results have made the news headlines without the usual peer review process. Just this past week, we have seen that, well, not even just this past week. I mean, South Africa originally thought that we would be able to use the AstraZeneca vaccine. That was curtailed. Preliminary results now on the J&J vaccine suggest that we should pause. It's not clear what the evidence is. There's been a lot of discussion back and forth, but I think that we are in a situation where we are building the boat as we are sailing. And it's not easy. It's not easy for the politicians. It's not easy for the scientists. And even though we've had 10 years worth of vaccine development with mRNA, to date, you know, these clinical trials have been rushed, very much rushed. And I can't say that it's all been very positive, but we're in it and we're having to deal with it. Next. So I just want to talk very briefly about the complementary value of scientific advice and public engagement. So in COVID, there was difficulty in setting priorities and making decisions in a resource-constrained setting. South Africa was in, or is in, a kind of unenviable position because we're a middle-income country, and the assumption is made that we have enough money to provide everything for everybody in terms of healthcare, and that certainly isn't true. A lot of the budgets were cut during COVID, the health budgets and other budgets, and there were trade-offs that were made that could impact the individuals and their health, their finances, the national economy. There's been huge amounts of hunger, nutritional consequences, and growing inequalities. South Africa was not exactly fully employed prior to the COVID pandemic. There were about 25% employment and unemployment, and there's now 35 to 40% unemployment, and that's the official figures. So we need to take into account all of those trade-offs as we are, as we managed I think we managed the pandemic really well, but there were trade-offs that were made. But this crisis requires unprecedented social buy-in And I just want to talk a little bit about public engagement. Thanks, next slide. And the need for public engagement. And we've done some work on this. We published an article in The Conversation Africa. And our public health approach has been largely scientifically driven, which has bolstered public trust in some interventions, but there hasn't been a complete transparency and engagement that has driven context-specific decisions. And these processes need to be better and to be deliberately informed by the legitimate priorities that are ethical and reflect public values, even if they can't be wholly determined by them. Next slide. So why do we need to engage the public? I think we need to just be clear there's several reasons. There is a democratic imperative, certainly in South Africa, to involve anybody who is affected. It reinforces legitimacy and acceptability. There's a moral importance for transparency and engagement, which should reflect the values of the people. And it should inform difficult decisions about priority setting and resource allocation in the context of COVID. There's evidence to say that it should reflect community health needs and barriers and facilitators. And very importantly, it can manage community expectations. So I think, yes, there has been community engagement, but not in the way that we think is needed. Next. So what the type of engagement really matters. So we've got on the left, what is non-deliberative engagement? It's limited to person-to-person dialogue and debate, and it's about surveys, focus groups, feedback meeting, and information gathering. A lot of it is quite passive. What we need is deliberative engagement and deeper engagement and consideration of competing views. We really need to understand what these competing views are. We need to foster debate and to provide a setting where values and moral claims can be challenged. And that will provide us with richer data on public attitudes and values. It educates participants about the issue in question as it is being discussed. And these can take the form of certainly public hearings and community meetings, but it's more around public panels, deliberative forums, and citizens' juries. And I think that this is really critically important in a situation where there's an anti-vaccine sentiment amongst some groups in the population. I don't know what that looks like in DRC. There's certainly some groups here in South Africa that feel that way. And I don't think we have been particularly good about engaging in a deliberative way with communities. Next. Just to give you an idea, we did some work on the value of COVID food assistance from the perspective of HIV positive women. There were very low levels of access to parcels and COVID grants amongst the participants. Everybody was promised food parcels, but there were huge swaths of the country that didn't get anything. And the individuals of these HIV positive women showed that they looked at these food parcels and thought they were nutritionally inadequate in quality, insufficient in quantity, and inefficient in delivery. And as far as they were concerned, the government should not have bothered. They would have preferred to receive cash or vouchers to food parcels. If we had had these discussions early on, it's not easy, we're in an emergency situation, but early public engagement could have helped to mitigate these adverse effects. Next. So as I said, during COVID, we had to make these decisions very fast, and the public were largely, I would say, excluded, especially the most vulnerable. We did gather insights into impacted vulnerable groups and what the social barriers and facilitators were. We investigated the policy responses in the food space and looked at the lived experiences of women living with HIV. Next. We also have done some research on some methods using deliberative public engagement. It's called CHAT, Choosing All Together. And we did this to help show that communities are actually capable of setting their own priorities, and they're pretty good at it. It's simple to use. It's like a game, and you distribute a limited number of stickers, which represent a budget, on a board to select the interventions. The community groups choose their own priorities, and we've modified it successfully in rural South Africa. And it's also been done in India, rural India, and it's currently being tested in Burkina Faso and Ghana, related to nutrition, actually. Next. So this gives you an idea of what's going on what went on in rural Bushbuck Ridge, which is near the Mozambique border, in a rural province called Mpumalanga in South Africa. And people had to choose between child health interventions, access interventions, lifestyle diseases. And it was very interesting. Right at the beginning of this work, people in rural Bushbuck Ridge said, you know what we really need? We need a X-ray machine. There are lots of road traffic injuries, and we're tired of being shunted to faraway hospitals, and we want a close by X-ray machine. By the end of all of this exercise, which took a couple of days, people said, no, we don't want the X-ray machine. It's too difficult to look after. It's very expensive. We don't have a radiographer. And to be honest, we'd rather look after our children and have HIV treatment. So people really do know, and they know how to do trade-offs and set priorities. We should not assume that communities are ignorant at all. They're very knowledgeable about how to do these things. Next slide. So what does this tool do? It's helped to show that citizens understand that not every service can be provided. Choices need to be made. They can identify their own priorities. They can understand how choices impact them and others, and when they can't choose everything. And we have also learned what is most important to communities. We don't do enough of this. Most of what we do is top-down policymaking. And I think that what we've done here is to show that priorities must reflect the values and preferences and meet the needs of communities. Next slide. So during a crisis, I would say quick engagement methods are necessary, supplemented with more meaningful engagement. Under normal circumstances, decision makers may have time to undertake a deliberative process with the benefit of data and scientifically rigorous information, but the allocation of resources during the time of crisis does not have the benefit of time and perfect processes. However, we have some existing tools that can be used and modified during a crisis, whether it's this one or the next. Surely this won't be the last. Next. So what are the key messages from my side? It's important to remember that policymakers have different expertise to scientists. Right now, as Dr. Abdool Karim showed, everybody is an expert, okay? But actually, it's not true. And policymakers do have different expertise. They understand how things need to be done quickly and logistically to get things done. It's important as scientists that we do our homework. There's not a lot of time, and so we need to make the best of it. We also need to get to the point with the policymakers, but don't oversimplify things. Make sure they understand where possible, and be persistent and patient. Don't be discouraged. It takes a long time to engage properly with policymakers, and we've been doing this for quite a while through our unit in South Africa. I think that's it. Thank you. Asante, siyabonga, merci. Thanks.
Merci, Professor. Merci. Thank you very much, Professor Karen. I learned a new word from you there that is called regulatory chapter, which is quite interesting to follow up and learn more about. And your take-home messages are very, very, very clear and straightforward. I appreciate that. Thank you very much. I will still encourage colleagues to keep on posting on the question and answer session so that we do the discussions once at the end. And I'd like to move on to the next part of the webinar, which is about presenting the findings from the Young Scientists Survey. We have two professors, Professor Sudesh Sivarasu from the South African Young Academy of Science, and also Dr. Muhinde Hippolyte from the DRC Young Academy of Science. In this webinar, the Young Academies have been brought together with the senior academies as part of working together and ensuring that this balance we are talking about and the science advice that we are talking about reaches, the younger population in the two countries. So these two members of the Young Academies have some presentations to make. I don't want to preempt what they're gonna say. Let's start with you, Professor Sudesh, and then we'll go to Hippolyte before we conclude. Over to you, sir.
Thank you, Dr. Barbosa. Good afternoon, colleagues, and bonjour. So today we're going to be presenting to you the survey that was conducted by the young scientists of South Africa and DRC. And to be a little more precise, so we had participants in the survey from across 45, like we had over 45 participants, and we had a few overseas, like non-African participants as well. Those were only 4, but in total we had about 41 representations from young scientists across Africa. And here is the distribution of various young scientists from different African countries. So I would want to highlight to you why this survey was conducted. The survey was primarily conducted to see how we can restructure and how we can incorporate younger scientists in policy and decision making. And so with that in mind, we posed a series of questions to these participating scientists across these countries, and then we got some very interesting results, and I would like to present them today at this forum. And along with me, we have Dr. Makovo from DRC, and I will go into the findings. So we asked them some simple questions like, what are the fundamental social media platforms that they use? And it was quite the obvious ones came out. So the Facebook and WhatsApp seem to be the obvious social media platforms that these researchers use. But we went on to ask what is the key information that they shared on these platforms. And then that was quite interesting to know, in addition to all the forwards and all the religious information that gets spammed in social media, there's a lot of scientific information that has been passed on social media, and we have more than close to 85% of responses supporting the transmission or sharing of scientific information through social media. And then we asked them what is the most common social media platform in their respective countries. And again, it stood out to be Facebook and WhatsApp. The reason why we asked these questions is basically to get an idea about if we need to reach out, if we need to do science communication to the younger population, what would be the right kind of media? Would it be still publishing, in paper-based media, or should we look at transforming how we communicate science to the younger generation? So that's the whole rationale behind this. And then we asked them what were the misinformations related to COVID that was circulated on social media. We had quite a drastic response. So one side we had, or close to 45% of the respondents indicated that they did not know of any such misinformation in the social media, whereas majority of others were talking to the point around how harmful were COVID vaccines. Then we went on to ask what were the specific incidents where these misinformations were. And I'm going to be presenting the next couple of slides. And you will notice here, there are thematic responses that would come out here. So you will see that quite a few people have been concerned about how vaccines are implemented. So predominantly they say vaccines are an issue. They also, there is a perception that vaccines are not safe because they were produced so quickly. And some believe that imported vaccines are contaminated, which is another perspective that was that came out in the survey. And the other misinformation that is quite prominent is that there is a belief that COVID did not exist in their country. So how do we handle this? It's going to be a very interesting challenge to scientists like us. So just going further on the information or misinformation that the people were exposed to. And this, I found this quite interesting. Some of the researchers indicated that the misinformation that they were exposed to indicated on how COVID vaccines were made to kill Africans. And there is a trend of information or trend of misinformation that is out there in the social media, and this is something that as policymakers, one would need to be aware of. And there is conspiracy theories around black race, biological extermination, quite a strong word to be used, and you kind of see that. And still, there is an indication that they don't believe that there is COVID-19. And as early as people started spreading rumors around how 5G causes COVID-19, and how misinformation of vaccine, it's all about business and not about health. So it's kind of quite a varied kind of response that we received. So we did a little further investigation, and we asked them, we probed them a little further, asking them, how many or were there a question around, we posed them a question around existence, or was there a question around existence of COVID-19 or not? And the responses were predominantly yes. So which means that there has been a lot of debates about whether COVID-19 actually exists or not. And then we found something positive. So here is where it gets a little interesting, and that's where I think as scientists or as policymakers, we start to make more impactful outcomes when it comes to public health and social measures. We asked them how reliable are the information that comes out in the public health and social measures in their respective countries, and we saw that 35% of people indicated that they are very reliable. Around 49% of people said they are reliable, and only about 15% said they are unreliable, and nobody actually indicated that they are very unreliable, which indicates that predominantly over 80% of the respondents felt that the information that was shared in the public health and social measures seemed to be quite reliable. And the public narratives around the public health and social measures in their respective country were generally positive and negative. So there was a combination of responses. So we went out to ask them, so who were the key drivers in their in the public narrative of their in their respective countries around COVID-19? And predominantly it happens to be the government and the media. So which makes the responses coming from these two sources more reliable. So we further asked them, how do they think the public understood the communicated messages in the public narratives, and most of them seem to be fine with it, and close to 40% said they didn't understand it further. So we'll come to it a little later in the later slides. So we tried to package this, and we posed them specific questions around how can the public health and social measures in their respective country be best packaged to make more public engagement, especially around the youth? And we got some interesting responses. So some of the scientists feel that involving more youthful icons would be a good way of approaching the current youth and the next generation people. And there was also a need for using simplistic language. So use of relatable language and not scientific jargons was highly recommended. And we saw that in quite a few responses. And there is an overwhelming response in terms of keeping it simple and clearer language and less authoritative language that gets conveyed, so that people can generally accept what is being communicated. And going further, we further asked them to be very specific how to get their youth engaged, and the responses that they had was to get their youths to be engaged and to raise awareness at various levels, including schools, churches, markets, and media. And then involving, there was another comment on involving young scientists to speak about these researchers and making awareness around these. And going specifically, to educate them in terms of more on COVID-19 virus and better communication of information. And they feel that good news should spread as fast as fake news, and try to get the information reached out to the public as soon as possible. And then the underlying message in this whole, the first part of the exercise was there was a call for engaging with more youth population, and there was a call for consistent and scientific or evidence-based driven information that needs to be communicated to the youth, and there is a need for something like that. And then we asked these young scientists whether the whether the young scientists' voice in their country is considered during policy formation or implementation, and we got a overwhelming no. More than 71% of the respondents indicated that young scientists' voice were not considered during policy formulation. So, which is something that I would like to present, and then I would like to stop with that and hand over to my colleague, Dr. Makowo. Dr. Makowo, over to you.
Yes, thank you for the floor, Professor Sudesh. So the next question that was asked in this survey was to know what are the sentiment over the government-imposed lockdowns and curfew. Here we can see that only 22% of participants thought it is generally accepted, and the other 24% thought it is good intention. But nearly half of the participants believed that the lockdowns and curfew lack the logic. Can we go to the next slide, please? Yeah, so we wanted further to know the explanation of the answers that the participant gave to this question. And here we can see a broad variety of answers as participants were from different settings, as we saw in one of Elia's slides, with a map showing the countries where the respondents were from. So for some of the participants, they thought it is a necessary evil, these measures, the lockdown and curfews. Others think that not all factors were considered before applying those decisions. And the majority accepted the curfews with an understanding that the measures were for protecting the people, but several people were still questioning their logic. Maybe this is due to the fact that the explanation is not given properly, so that the perception can go in all directions. Can we go to the next slide, please? Yeah, we're still moving on with the explanations that were given by the participants. Some people think that as the pandemic is lasting, people are becoming tired with all these measures. So they are applying them less and less. Some reasons were these measures are good for the prevention of the COVID-19. Others think it is for the safety of the country, which is good. But we also saw that some participants believe it is pretext behind which politicians and the government are hiding for not applying their what the population expects from them. So now with COVID-19, it is easy to say we cannot work because of the pandemic. And also other participants thought this is a reason for government to take the money of the countries. May I have the next slide, please? Yes, still moving on with the explanation of the reason to the answers. We see that so many participants still are still in the good opinion to say the lockdown is for the welfare of the citizens. But then, you know, in most African countries, the informal sector is quite broad, and then there are not clear rules to cater for this informal sector. And also many people live on a daily basis, so imposing lockdown is very hard for those populations. And some arguments also were that our government are just copying and pasting the rules applying in other countries without taking into the account the local circumstances. The next slide, please. Yeah, some people think the lockdowns did not have any impact on the prevalence and the incidence of the disease. Here again, we think if the explanations are given clearly and properly, then the population may see what is the good of these strategies. And yeah, another question is, when there is a curfew in the evening or during the night, it is not clear to people if the virus is sleeping during the day, and then it starts spreading in the night. So that is also something not that sounds not to be logic. Next slide, please. Yeah, here we can see that we wanted to know the police enforcement of public health and social measures. Was it generally accepted by most social media users? We can see that 38% of participants disagreed. Only and 42 participants agreed that that police enforcement was accepted by social media users. The next slide, please. Here we can see that the public health and social measures were easily accessible for 69% of participants, and only 22% did not claimed not to have access to the public health and social measures. Next slide, please. Yeah, the presence of police in social and mass gathering to enforce public health and social measures was found to be acceptable by 20% of participants, but half of the participants criticized the presence of the police in social and mass gathering events. The next slide, please. Yeah, there are concerns that were raised that on social media platform that police would unfairly brutalize citizens or exhort them. That was reported by 40% of participants. Here we can see, for example, police taking mobile phones of citizens when they are walking around beyond or during the lockdown time. So there are participants who fear that the closing of social gathering would last indefinitely. Next slide, please. Yeah. No, go back. Come. Oh, okay. Thank you. Here, the concern on social media platform are that also police would give punishment that may seem harsher than the offense. This one was reported by 40%. We heard in one place that a citizen was shot dead because he did not wear a face mask. So that is harsher than the offense, and it is feared by some participants to the survey. The next slide, please. Yeah, then we wanted to know what should young scientists do in order to change such perceptions in future pandemics, maybe even during this one, because we don't know yet when it will end. So here also we have broad ideas, suggestions. Young scientists should endeavor to make their voices heard more forcefully, and also communicate clear messages to disseminate into the community. They should engage and voice their message opinion, being active by participating in government policies that can be feasible if they are invited, which would be really something very helpful. Can we move to this next slide as time is rushing? Yes, further suggestions that I try to pick some of them. We can, the young scientists can help to produce a message that make people feel involved. And here we have noticed that the communication is really the key, lacking in the community, because people do not understand the rationale of the public health measures. So involving the young scientists can contribute to improve the communication and also involve them in decision-making process. The next slide, please. Yeah, the young scientists should be given full support and infrastructure by their university. The challenges relating to research infrastructures were raised by previous speakers. So that is really a great challenge that needs to be worked on. And the young scientists have to work also with the government. This was raised already earlier in other words. We can move, please. Yeah, this is to thank you for your attention.
Thank you, Dr. McCall. In conclusion, the data that you see here has been, raw data that we have acquired from the survey, and we haven't polished the data. We have just presented it as is. And the follow-up of this, we would be presenting this information to the Global Young Academy, and we'll also look to publish an advisory and share the findings with the US National Academies of Science. And here are some of SAIS, the South African Young Academy of Sciences social media platforms. Please feel free to follow us on our social media platforms. With that, thank you very much for this opportunity. Thank you, Dr. Maposa.
Yes, thank you very much, Suresh and Dr. Hippolyte, Professor Suresh. Sorry for that. Thank you very much for that survey, which really is a cry from the young academies to be involved more, maybe to get some mentorship from the senior academies and participate together and develop messages and engage more and more with government and also themselves to participate in the future issues that are related to this pandemic. And I'll give this over to Phyllis now, but Phyllis, I indicated to you that one of our colleagues from the DSI would like to make an input, but you will see in terms of time and how you manage that. Over to you, I'm finished. You are muted.
Yes, sorry for that. I was saying thank you, Dr. Maposa. I'll just dive right in and unpick a few comments and questions. So one is from Petrida Ijumba. He or she asked, how do you get the Ubuntu philosophy translated from theory to practice when the gap between the rich and poor is in South Africa remains so huge? Professor Quarraisha or Professor Karin Hoffman, would any of you want to respond to that, please?
Quarraisha can answer that. I think it was something Ubuntu was raised during the talk.
Mm-hmm.
So I don't think Ubuntu has, it is a philosophy that is not outside of the economic challenges that face us. But I think part of addressing inequities, which can't be done all at once and progressively, is about working with a unity of purpose. And when you have unity of purpose is what we're really trying to get to as an aspirational process. Thanks.
Oh, there's sorry for that again. There is a comment to you, Professor Quarraisha, to share the link. Please share the link to the article on the variants that you had in your slides. And then there was a request from Professor Hankanu for you to share your presentation. And then what else? I just have to go through this one by one. And then Janine Nicole, and this is directed to you, Professor Sudesh. Quite interesting findings, Professor. I wonder how the community in the DRC and here in South Africa share same views on vaccine with this young scientists. Hence, active community engagements, this includes faith leaders, community leaders, young people, etc. Using bottom-up approach is required to mitigate some of these views. Any comment on that?
Thank you, Phyllis. Thank you, Janine, for a very interesting question. And I must clarify that this is not just a response of DRC in South Africa. We had other 18, in fact, other 21 different countries which responded to this. So you will notice a trend that majority or young scientists across Africa and some overseas scientists as well have come across the views of and concerns on vaccines, so which is which is quite a factor for us to consider. And I agree with you that we need to have a combination of bottom up and top down in terms of making sure that the information is disseminated in such a way that not only the educated population gets the information through the science advocacy platforms that we use, but also the bottom-up, the community gets information through the faith leaders and community leaders, and especially young children and learners get more clarity on what needs to be done in a scenario like a pandemic. So it's more than a comment. It's just a comment, not a good response. But Dr. Mavoko, if you have anything else to add, you please feel free to add.
No, I have nothing to add. Thank you.
All right. Thank you so much, Professor Sudesh. And there's our colleague, Ms. Mampei Chaba, wanted to give some input to the meeting. Ms. Mampei, you're welcome to speak. Doctor, can you please unmute her?
She is unmuted. She should be able to speak.
Mampei?
Yes, thank you very much, colleagues, and thank you for giving me this opportunity this afternoon to make a few remarks. I'd like to thank the Academy of Sciences of South Africa for organizing this session together with our colleagues at the DRC, the Democratic Republic of Congo. I work within the continent responsible for engagements in Africa, and the remarks I'm going to make are partly based on those experiences and what we are trying to do about that, not just as the Ministry of Science in South Africa, but also working together with the Academy in supporting the continent. So policymakers are really faced with difficulties when it comes to decision making, especially in times of crisis, such as the time with the pandemic. The decisions that they have to make have to respond not just to the health crisis as we have seen with the pandemic, but have to take into account socioeconomic factors, have to take into account geopolitical dynamics, where sometimes we have to manage possible fallouts with strategic partners. We also have to consider national politics, especially in a country like South Africa, where civil society is quite active and vocal. So there is a lot that policymakers have to take into account. It becomes even more challenging for policymakers to make these decisions when in the same regions that they operate in, which are in close proximity, different or opposing decisions are made based on different scientific advice. Therefore, scientific advice has to be accurate and evidence-based and has to be agile as well. We've seen in the times of the pandemic that information keeps on changing based on the results we get from the various clinical trials. And policymakers have to be advised as those changes occur so that they're able to make appropriate decisions as those changes occur. So the lack of a coordinated science advisory body or bodies, either at national or regional or continental level, makes it even more difficult, especially when scientists do not see eye to eye on an issue. It leaves the policymaker having to make the difficult decision of discerning what is more accurate, what is true, what is the agenda behind the science advice that is provided. The role of science academies then becomes critical, as they can coordinate this science advice that can be provided to government in a coherent, coordinated manner, especially if it has consensus from the scientists themselves. Then when it's presented to policymakers, it's one voice, one piece of evidence that says we as scientists say, then it becomes easier for policymakers to make that decision. For a continent such as ours, it's even more difficult where in some cases science academies do not even exist, or where science bodies that coordinate science do not exist. So it leaves policy makers in a state of paralysis, especially in times of crisis such as this one. And that is one of the reasons why South Africa, during its chairship of the AU, proposed an African platform for science advisors, where science advisors in the continent can be made aware of the issues to take into consideration when advising policymakers, can also be made aware of emerging issues to be considered when providing advice to policymakers, and provide that advice in one coherent voice. This platform, ASSAf, was a collaboration between the South African Science Ministry, the African Union Commission, and the International Scientific Council Regional Office for Africa, supported by ASSAf. We are hoping that the African Union Commission will soon make an announcement on its launch, and we urge scientists in DRC, in South Africa, across the continent to join this platform and organize themselves in a coordinated, coherent, evidence-based, to provide evidence-based advice to policymakers to ensure that we stop being paralyzed when it comes to making decisions on behalf of our citizens. Thank you. Thank you, Phyllis.
Thank you very much, Mampei, for those brief remarks. And as all participants may have noted, please keep your eyes peeled for the for ASSAf, which will be launched soon by the African Union Commission. And just to ensure that I do not break protocol, Ms. Mampei Chaba is the Chief Director in charge of Multilateral and Africa Cooperation at our parent ministry, the South African Department of Science and Innovation. So I have just scrolled through the chat box once again, and I cannot seem to see any other comments other than I see here Janine Nichols has just dropped a comment to Ms. Mampei. Is there a way to share the link for this African Union initiative? As she stated, it is yet to be launched by the African Union Commission. So once we have this information, we'll surely share it with the participants of today's webinar. I can see Professor Hoffman, your hand is up. You can go ahead.
Thanks. Thank you very much. I just wanted to, in the question and answer box, there were a couple of questions that I just like to address. So in South Africa, the majority of people who were hospitalized and died from COVID have had an obesity-related condition, either hypertension or diabetes. And this really points to the fact that what was discussed earlier is that there's a colliding of many different epidemics going on at this time. It also highlights the need very strongly for prevention of obesity measures across the continent. In some countries, there is more or less obesity. South Africa certainly is the most obese country in sub-Saharan Africa, and not something that I'm proud of. But I just wanted to say that the one question related to whether exercise was helpful during COVID, and there was actually an article I read this morning, I can't remember exactly where it was, showing that actually people who exercised seem not to get as sick. So anyhow, I think the issue around hypertension and diabetes warrants serious consideration, because we can't wait for people to get sick, and the processed foods that are flooding our continent, because this is a growth market for many companies, needs to be seriously addressed. So I just want to thank you for that opportunity to mention that. Thank you.
Thank you very much, Professor Hoffman, for those additional remarks. Yes, I actually did read that article about people exercising. I think it was a study done in the US, but it really just goes to show how it is applicable all over the world. So just an urge to every one of us to keep it moving at a minimum of 30 minutes a day, just to be on the safe side. So my clock says it's 8 minutes past 4 p.m. and I think it would be fair for everyone in terms of time who has taken time out of their busy schedule to join us in today's webinar. And before I do that, first I would like to sincerely apologize for the technical breakdown in the translation. We tried to fix it, and I think because it is the first time we have attempted such, it failed us. But we sincerely do apologize, and we will improve in the next webinar that requires translation. So I would just like to take an opportunity to briefly thank all the speakers, my colleague Dr. Maposa, Professor Chilolo, Professor Quarraisha Abdool Karim, who unfortunately had to leave the meeting to join a brief meeting for a different study that they are conducting, Professor Kayembe, Professor Hoffman, Professor Tivarasu, Professor Muhindo Hypolite, and I would also like to thank my colleagues behind the scenes, Mr. Tomorokong, Mr. Kolani Mbiza, our colleague from the US National Academy of Sciences, who have graciously funded the 2 academies for this project, and which have been led by Ms. Patricia Cuff. Thank you very much. I can see you are tuned in. And all colleagues at the DRC Academy for accepting to partner with us in this webinar, even though you are very new, you're very fresh, just having been launched. And last but not least, to all the participants who are just staying tuned, even though we have run over our allocated time. We cannot take it for granted that you have stuck with us, and without you, the participants, this webinar would not have been a webinar. So thank you very much and have a lovely evening wherever you are, and stay safe. Thank you.
Thank you.
Thank you, and congratulations for the very nice organization.
Thank you very much.
Very nice. Thank you.
Thank you.
Thank you, Dr. Maposa. Thank you, Dr. Kalani.
Can I just ask all speakers, the ones remaining, please switch on your camera